Okay, good afternoon. Hello everyone here on site and on YouTube. It's 1 p.m. and it's time to start our seminar. It will be a little bit different from the ones that were in the past, where the specific groups from our institute were presenting what they do in their everyday work. So now we are switching the formula to truly scientific seminars. And the idea is to have this seminar every other week. And the presenters will be from the institute and from outside, also from abroad. This is something that was bothering me for some time already. Because within the frames of our HR Excellence Award that we received last year, we declared that there will be this type of activity set permanently. This is something that was missing in our branch. I know that this is working in Gliwice and in Krakow. We are doing seminars internally in our departments, in our clinics, but this is not something that fulfills this seminar for the whole institute. Together with this change, there will be some additional requirements for the scientists, because this is something that should be mandatory for everyone that is hired in the institute and does science. So not today, but sometime in the near future, there will be a list of attendance for every scientist, for every PhD student. And this list will be taken into consideration during evaluations of the scientists. Basically, if someone doesn't meet certain number of attendance, this evaluation will be negative. So that's the goal. But on the other side, there will be some also encouragement for the attendance that will be connected with what we call scientific bonus. It will be like an annual additional award from the board of directors for the scientific achievements. And in order to get one, we will be also looking at the attendance at the seminars and at the conferences that are organized by our institute. So this is this announcement. This announcement about the changes in the organization of the seminar. And now I would like to switch to the main topic of this meeting, the presentation of Rafael Carretero. Yes, that's correct. So there is some personal story behind it, because I was the one that Rafael contacted about a year ago, asking if he could join, or at the moment just to visit our institute, because he has some interesting PhD project. And we exchanged the emails, and then I contacted his PhD advisor. Luckily, the PhD advisor of Rafael is also the advisor of Professor Mańczuk. So this is something that makes me wonder that there is always a serendipity in our everyday life and also in science. So we have to catch the opportunity, and that was the one. So Rafael, probably some of you interacted with him because he was, wandering around the institute, but not as a patient, but as a specialist that does his scientific work, and hopefully he will help us out at some point to redesign the interiors of our old building, and maybe he'll be involved in the designing the new one. So, Rafael, the floor is yours.
Dzień dobry wszystkim. Dziękuję profesorowi Mikule za wstęp. Przepraszam, dopiero uczę się polskiego, dlatego prezentację będzie po angielsku. My name is Rafael Carretero, and today I will present a seminar on the role of infrastructure in cancer care in 2025. Specifically, I will discuss the digital twin of the oncology infrastructure of our oncology center that I developed as a part of my PhD research. Just to begin with, for the ones who don't know me, I'm an architect. So I'm not a doctor like most of you, but I am a firm believer that the environment shapes the experiences, and it is very much related to health. That's why I did my master's in user experience. Since then, I do not see architecture as an art, but as an interface where patients, especially oncology infrastructures, where patients interact with the health system and with all the other different factors that they have to carry in such a stressful period of their life. And that's why it led me to a PhD that I just finished in general medical sciences and health services with a focus on health infrastructure. All of my projects began with the questions if our oncology infrastructure designed for treating patients or for treating cancer or for treating patients with cancer. This question has shaped my research and this presentation today because especially in the case of our institute, due to its age, the time is often seen only as a container, and it leaves the potential of it completely underexplored. So, traditionally, the role of oncology infrastructure has been to serve as a container for delivering treatments that improve the biological conditions of patients. As a result, numerous guidelines exist to minimize the risks that infrastructure puts for materials, biological hazards, chemical exposures, and others. However, following Angel's biopsychosocial model of the aspects of health, there are three dimensions interconnections: biological, psychological, and social. However, these are not currently addressed in the oncology infrastructure. But the question is do they become a risk for the patients in such a period? Well, in cancer care, these three aspects are particularly very interconnected because of the physical consequence of the cancer treatment, which have implications in the psychological and social factor. Additionally, recently, depending on the diagnostic results, a tangential aspect of spiritual well-being might also emerge, especially when the prognosis is severe. That doesn't happen a lot, but it's something that while my research in Poland, it was very present. In this context, the built environment serves as the interface where these aspects interact. As these processes take place in a physical setting, this physical setting fits into the definition of built environment. And that's where the research started originally. So, searching if oncology infrastructure that falls under this umbrella of built environment, what is this current status about oncology infrastructure in research? Research in oncology infrastructure has mainly focused on the distance between patients' residents and the oncology infrastructures, often considering also neighborhood factors and pollution sources or exposure to carcinogens. It has been linked to these factors to outcomes such as treatment adherence, treatment choices, because patients normally choose the treatment based on the distance, quality of life. However, the role of oncology infrastructure is still underexplored. In fact, the architectural and the organizational characteristics of the infrastructure have been underlooked, and this underscores a gap in research regarding the role of infrastructure. This gap is especially significant because the infrastructure is the only common interface to all cancer patients. It's where they experience their physical, psychological, and social consequences of their illness. For that reason, and not only, but also because of the constantly multiple challenges that infrastructure for its physical characteristics that it can't evolve, because it's a material thing that stays, the increasing number of patients, the difficult physical and psychological conditions, and the high maintenance costs, it's been like merely seen again as a container. Moreover, an institute like ours, whose situation reflects in many European countries and others, must address the quick questions like, has it adapted to the demand? Has it ensured patient safety, security, and well-being? Does it adapt to the evolution of treatment and technology? Like, how, thinking back like 20, 30 years ago, like the machines were different. Is their space misunderused? How can we take advantage of this space? Does it integrate technological advancements? Like right now with sensors and all the biotechnology developed right now, like infrastructure can become a tool more than a container. Does it enhance patient-centered care and well-being, which is right now the core of cancer care, right? And regarding other actors, like does it optimize workflows and operational efficiency of doctors or workers? And one curiosity, what will happen when telemedicine is fully implemented? What will happen to these spaces? What will happen to the physical infrastructure? I mean, a physical infrastructure will always be the reference. But how can we take advantage of the physical spaces that we have and the constant challenge that we will be facing with increasing patients and also managing technology? And also, but not finally, like, does it promote staff well-being? Because in fact, my thesis focuses, and I have analyzed infrastructure from the point of view of patients. However, there are many actors involved for which infrastructure also plays a big role, especially like in medical staff life. So, what is the role of infrastructure in healthcare delivery in 2025? Does it impact health outcomes or health delivery? And right now, with the creation of the European Cancer Comprehensive Network, we are promoting like quality treatment all around Europe, safe treatment, but are we promoting the same environment? And I'm not talking about the design, the style, how pretty it is. It is about like how well does it work, the infrastructure for its purpose. For that reason, and with the advancement of technology, we now have opportunities to address this gap and unlock the potential of infrastructure. The availability of building information modeling allow us to explore how scaled infrastructure can evolve from being a container to becoming a functional tool. A digital twin in architecture, it's an architectural tool, is typically used to collect data on infrastructure such as geometry, structural integrity, mechanical, electrical, and so on. But all of this, again, fits into the architectural work. So what I tried to use was to use this tool to make kind of in my PhD an interdisciplinary collaboration. Because as an information model, it enables the integration of new data, which opens the possibility of this collaboration, especially to include data that allows us to understand if the infrastructure is really responding to the challenges experienced by the users, either patients or workers. So the BIM model of the Institute was first used to understand the shell of the Institute, like how is it organized. We see here like the two entrances, all the pavilions that are connected by bridges that go through patios. Most of the pavilions have 2 floors except of the pavilion F for biosafety reasons. And then we have the Tower of Clinics. When I did a deeper analysis of the infrastructure to identify the public permanence and the circulation spaces outside of treatment rooms, because there's one thing, like what I'm trying to do here is not to compete with already manuals existing for designing hospitals or biosafety standards. Is to complement them, because as said before, like infrastructure as a container for treating cancer has developed off this manual to ensure the biological safety of the patient. But does it ensure the psychological, physical, and social well-being of the patient? And that's why I decided to study all these spaces. I don't know if it's seen, but the purple part is the circulation spaces for the patients, which you can see go through around all the building. The yellow parts is spaces where the patient can circulate only if access is allowed by the doctors. This is the second and the third floor of the outpatients rooms, where also patient circulates. This is important because it's especially when patients are not in treatment, such in waiting rooms and corridors, that their anxiety or their uncertainty levels increase according to research. Their needs become more pronounced as the lack of direct interaction with patients, with doctors for reassurance or for information. I did my project studying breast cancer patients, as they were the most respondent to my service. And when I analyzed the patient flow, in order to detect the transited and permanent areas, the circulation flows show a movement all around the complex, depending on the treatment stage, depending on the type of treatment. So it's basically all the building where it's used by the patient. This mapping allowed me to identify 21 architectural and organizational characteristics of the oncology infrastructure related to patient physical, psychological, and social well-being. I will go through the identification of all of these aspects, but take into account that none of them refers to aesthetics. This was not about how pretty it looks. It was about how good it works. There are spaces where the oncology infrastructure lacks of physical support, which is a relevant factor for the physical and psychological well-being of patients. Additionally, there are also identified several physical elements without a function in the building that just diminish the experience of the building or complicate the transit of beds, doctors, and so on. In the case of information boards and totems, they are supposed to provide us with information. This is what we find in here. We have several types of distinct information boards, but do I wonder, me as a patient, does it help me or does that confuse me more? Waiting on corridors vary in characteristics, but I just decided to put these 6 pictures in here because the topic about natural light has been very wide studied in medicine, not particularly in oncology, but it has been wide studied that natural light is important, and this is the state of the corridors in our hospital. Additionally, the physical status of the infrastructure might represent a risk for the patient's physical well-being. And this can be either to the lack of organization or the lack of spaces. There were also identified several types of flooring, but what is the role? I don't know if you have ever noticed, but in user experience, we have this experience of shadowing. You put yourself into the role of a patient. You go through that. Do the floors tell you something? They can't. There's so much potential, but they just confuse you. Finally, there's a total of 13 patios inside of the infrastructure. None of them with correct accessibility means, and none of them being used by patients. So, what is that? Additionally, the only clinical space I included in this project was treatment rooms, because now the outpatient service grows. As the outpatient service grows, it's a place where patients deal alone or with relatives. They have the physical surveillance of a nurse, but they're basically on their own. So their permanence and the state of this space might impact their well-being. One other important factor that I took from other studies that I already identified was the urban accessibility to the center. you know. Our center has 4 main entrances, with the main one being in the ulica Roentgena. You can see like our building is surrounded by all of circulation paths for cars, but at the same time for a lot of parkings. And little is known that like cars normally take on top also like green areas, and there is no space for circulation neither inside the patios or outside the patios. The circulation possibilities, I just did this 3D to show you how the patients go up or go down, which is, of course, the only place where they have to go up is the clinical towers, but there's just 2 elevators to go for an amount of patients that I have not been able to really to retrieve the data, but there has not been a single moment where patients have been left out of the elevators every time I have been here. I go back again to the patient flow within the infrastructure, and this allowed me to identify the distance between buildings, and there is a lack of connectivity between Pavilion C and the rest of pavilions, which is, allow me the word, funny, because in the Pavilion C there is the pain clinic, which is like people who goes with like under big pains, and so if they by mistake go in the main building, or if they have to transit between the 2 buildings, there is no possibility of connection indoor. I know there is in the basement, but that's a labyrinth. Finally, the red points represent the receptions, and the darker purple marks represent the sittings. There is not established waiting room in the infrastructure. There is the main waiting room in the middle, but where does it take you? To the eating room, to the information desk, when the main flux of patients happens in here, in the outpatient room. Also, like the comfort, like the seating possibilities and how they are distributed have a very big potential for the. It has been studied in people with morbidity cases and people with high pain, and it has the capacity, depending on the organization, on isolation. But we in the hospital identify different standards of sitting, but do they respond? Like that was the question I always had. Like, do they respond something, or are we just managing the infrastructure as how it comes? Finally, this is the services all around the infrastructure, which we see like they're mainly concentrated in this very big avenue accessed by the main entrance in ulica Roentgena, and then like spread out some services, which is like also like very interesting, is that the pharmacy, the apteca, is outside in Pavilion C. Besides, when patients have to access with the hard conditions of winter in this country, we might expose patients to unnecessary risks. And these are the pictures of the services in the main corridor. Again, here they are, the 21 factors individuated. But what I did with these 21 factors was to cluster them in six clustering: navigation and wayfinding, information and communication, accessibility and comfort, spatial organization, environmental quality, and physical infrastructure status. I did this in order to transform them into measurable factors that allowed me to continue with research. First, I gave a objective score depending on the status of every of these components included on every of these clusters. Then in my PhD project, I developed a PVA index, which is like a physical built environment index that refers to the status of the infrastructure. And I collected data from patients. And I also collected their well-being, the infrastructure, based on World Health Organization 5 Wellbeing Index. The results were this. But what was more interesting was that the ones linked to the well-being of patients were the ones mainly linked to the physical well-being of patients, which that's by origin the purpose of the infrastructure, you know. Additionally, there is a little bit of bias, in my opinion, in the environmental quality, because as patients do not have the access or might not have had never the access to this Patterson site, they do not know what infrastructure can offer, right? But the most important part, and why I developed the digital twin, was like the organization, the special organization and the information and communication, because that's the potential that infrastructure has to act as a tool for cancer care. Just visualizing the maps, like the red, the more red the color, the lower the well-being of the patient is in this area. And this happens in the first floor, which like, and the confusion part between Pavilion E and Pavilion A, K, and Pavilion K. And we see it as well, like the main or the most appropriate area for well-being of the patients is in the radiotherapy pavilion, which we all know it has a good waiting room. This is the second floor, and this is the risk in the different floors. I just emphasize on the risk of the fifth floor, which is the breast cancer clinic, because that's where I had access. With the digital twin, we were also able to identify the underused space all around the infrastructure. In the ground floor, all the patios, the parking in the entrance, and all the surrounding green areas. In the second floor, there are floors where right now there is maintenance machines or mechanical equipment that is needed. However, the repurpose of the reinstallation of this is not complicated. And then in the second floor, the roof of the ceiling is like, can it be used? But the question is like, what does it represent right now, like having a digital twin for our institute? You know, like a digital twin is not only, or what I'm trying to do is not for only having the architectural measurements of the infrastructure and knowing how you're going to change, because it's also able to tell us how is it going to cost, what material, the calendar. But if we align this with the well-being of patients, the results can be very successful. So after creating this digital twin, we select the users, we select the risk area or the challenge that we want to face in the oncology infrastructure. We select or collect the data, which is like, with the integration of sensoring and the inclusion of artificial intelligence within the infrastructure can be way easier. And plan and test the intervention virtually before executing. And after executing, collect data in order to promote like that these changes are not only being done because they're pretty, like, or because they look good, but because they are promoting like an improvement on the patient. So, if the user is a patient, the tool is used for patient-centered design. So to improve these spaces for the patient. If the user is the medical staff, the digital twin becomes a tool for operational efficiency and a risk minimizer. And if the user is the medical administration or the hospital administration, it's a tool for operational and economic efficiency. So, just to finish, I did a testing of indoor and outdoor areas inside our infrastructure, which these are not the only ones that I detected or the possibilities of change, but the most relevant. So first, the indoor testing for infrastructure as an interface is what I call resilience road. This avenue inside our hospital has the potential of being so great, of being a reference for guidance. I think what we are left, I mean, the architecture that we are left with is unique. And there is no other spaces that have the amount of patios we have, but we need to understand how to use it. Because right now, I completely understand the good intentions, but we need a little bit of planning, and that's what the digital twin is used for. This is what's being done around the world, but this is in a different sector, in the private sectors, in the NYT hospital. And this is the Copenhagen Diabetes Center, which is a different target. This has not been yet done in cancer care, especially justifying the aesthetics, not only for the aesthetics, but for their impact. There are strategies that have been applied all around, like the wayfinding, the technology inclusion, the branding. We just got a new rebranding of the branch of NIO, and we barely see it around. The innovation, the motivation, which is, it was very funny because I had a moment in this institute where somebody left a note and people started, of course I used my Google Translator, people approached this note and started like smiling to it. And when I went to it, it was like, you have a nice day, everything is hard. And I think like these things for such a moment is kind of like interesting to have and to apply within the infrastructure, the interaction and experience. The experience we can promote into this, what I call resilience road. Additionally, I want to show this image. These are two corridors separated by a wall. So does it make sense? I know like the infrastructure has been on so many modifications since it was created and reorganization of spaces. However, if you see here, there is a full wall that contains 4 columns that could liberate the space and could they make the infrastructure or the center have a proper waiting room closer to the outpatient room. Finally, the outdoor testing. First, I decided to do the testing with the patios inside the infrastructure, which their condition lacks of accessibility, the maintenance, there is no utilization, there is no connectivity, it's a lot of inactivity. It's very funny because like sometimes wall face the patio, and yes, I agree that like some of the spaces are like completely biological and medical safety measures, but on others, it's just like there is a patio and a medical room in the front, and there is no window. Don't know why. This is what is being done in other hospitals. This is like I just wanted to bring an example for children because that's the easiest part. Not the easiest part, but that's what we architects tend to do because we understand the children, games, plays, colors. My PhD was a challenge to understand a cancer patient. This is how like the roof of the Sokohawa clinic in Bangkok is being used. This is a private sector. It's not wrong that we aspire on that, but it's possible. And finally, I just want to leave with the patio strategies, like there's so many strategies and so many possibilities to be included in the patio, like the sitting, the activity, the technology inclusion, the meaning, the sensitivity, the spirituality, the comfort, and especially the history. This is the proposal for the design strategy. We have such a linear building, and then we have linear patios. Yeah, of course. There is also research about the effect of curves within in design and within experience that could enhance the well-being of the patients. Finally, the differences between the patios, the ones that are more restorative and the ones that are more therapeutic, because the plan would be like to do therapeutic patios for active promoting healing. In other words, like giving the patient possibility to do activities, the restorative patios, which is like more passive and mental restoration, and the contemplation patio, which includes like the 4 patios that are accessed only by doctors, which is like more like a observation patio for the users. The outdoor space optimization of these 4 gardens, if we can call them gardens, or like green areas on the corner of our institute, and I'm referring to these areas like that, the entrance to Pavilion D and E. I was like, there is no main entrance, there is a lack of clear wayfinding, there is limited accessibility, there is high pedestrian flow, and there is a lot of people smoking in the basement, which this consequences not only affect themselves, but the patient is in the building. So I was like, if we just need one exit in the hospital, because the other one's closed, if you can see there's one exit in here and one exit in here. If you need, like, let's do a patio that is capable of, like, I'm not saying like giving this possibility to smoke, but like, you know, like freeing the ones that do not to this contamination, giving space for like waiting outside within the good spring months we have here, and so many other possibilities. Finally, the main entrance, and I hope I don't enter in conflict with this with anybody, but it was like, this is the status, right? Like this beautiful park that I discovered very late, and this kind of hidden staying part that is not used by any of the patients. I have seen maybe within a year, no more than 20 people using that, which is which has a huge potential for using. Well, these are the problems that I'm not gonna like keep repeating because they're the same as well. But also, like, here it happens again the same. The concentration, like we see it like during the good months and the good weather, our patients tend to be outside. Our patients tend to want to breathe from the oncology infrastructure, and it's not been done. So it was like this was this idea that came up after like re-seeing the big model, which was like, let's make a rondo. Just make a rondo Marie Curie where we just like embrace her history and her role and not have her hidden in the back of the corridor. As I'm not Polish, but I have had like a love for this country for the last 11 years. And I got to know Maria Skłodowska-Curie was Polish the moment I joined this institute. So it was like, let's do it. And finally, the ampliation of departments. It was like, there's 2 areas that I know they are being used right now as a private parking, and this back area that is used for nothing, which is very funny because this window where I took the picture from is the relaxation room. So it's a relaxation room next to a patio with no access to the patio, and this patio has no access from anywhere around. So it was this proposal, you know, like the ampliation of the Pavilion D and the connection between these 2 pavilions. And there is a space to relocate this private parking with the same conditions in this green area outside. So this is the current state of the infrastructure, and this is the proposed state of the infrastructure, just like enhancing the use of the spaces, but also like by enhancing the well-being of the patient and the rest of the users. Finally, as a conclusion, like the digital twin is a powerful tool for optimizing the infrastructure use. The digital twin ensures, because it allows the testing, that the infrastructure meets user needs with real-world applications and a lot of benefits that the interface itself gives you. And how I started this presentation, like it moves oncology infrastructure separated from architecture, because it does move from like the subjective architectural decision to focus on evidence-based planning and the possibility of studying the infrastructure as a tool to enhance cancer care, which fosters new interdisciplinary collaborations, what we're looking at. And it's crucial as an international institution, an international recognized institution, that we focus on that, because that's where we deliver care. And finally, like, this is a tool that can be replicable in many other centers. And I just want to finish the presentation with this phrase, which is like, in an oncology infrastructure, it's not only about how good it looks and how fast it solves the problem, it's about reaching the full potential of it. I know this was made by some donations and so on, but behind that wall, there is a patio. And I cannot believe, if I am being diagnosed in any stage of cancer, being sat there waiting, the anxiety levels it could increase. I'm not saying that the window will solve the situation, but it will improve my experience, and who knows what else. Thank you.
Thank you so much. It was not a typical research that we are doing every day here in the Institute, but I think it's important. And for us as a users of this infrastructure, and also the main reason are the patients. Yeah, so thank you for your work. I'm hoping that some of your solutions will be used for the improvements. And maybe there are any questions.
Thanks for a great talk. So I wonder, talking about this institute, so as an architect, how would you say, what is the, let's say, bigger problem, the design which was made years ago, or the current implementation, how we use the space?
It's the current implementation. Because if we would have tested the organization before of how we organize our departments in a digital twin, we could have improved not only work flows, but only patient flows, and like use the spaces in a way that it's better, the space is better used for the appropriate use. Like, just to quote an example, like one of the most transited areas that is not a clinical consultation is the church or the chapel, which is in a hidden corridor, which like conglomerates a lot of people. There is an accessibility of it, or like from the main entrance, how to go from the main entrance in Roentgena to Pavilion D. It's a labyrinth, which is like, if we just like, we leave the shell of the infrastructure itself how it is, because we cannot change. The structural conditions of the infrastructure cannot be changed. But we modify the spaces within it. We can, like, I'm sure, like, have a quality space, one of the best ones, because of the patios. The patios are like a tool that we are not using. It could be used so much.
Any other questions?
Thank you, Rafael, for a great talk. And I just wanted to ask one thing, because many times I was wondering about exactly same things that you were talking right now, and because we had those talks. And many people told me that, well, nothing can be done in our institute because we are limited by space. So whatever you would like to propose to improve the patient's experience here inside the institute, you would need more space. And I just wanted to hear your opinion about it. Like, do you agree with this, or you think that there are some things, simple changes that don't mean lots of cost and you don't need more space to implement them. Like, can we do anything without building 3 extra compartments or whatever? What do you think?
I mean, like this I cannot show anymore, but like the doors would be the easiest change, right? Like there is an excess of doors that lead to nowhere. There is one thing I didn't put in the presentation, like the plans. I know the plans are trying to, like, you know, like enhance the beauty of the space, but the message they are transmitting is the mess, the disorganization of the space, because we have amazing patios. Do we need plants inside? That's the question. Isn't it better to like make it look clean and polished? Doesn't it improve the patient's perception? I did the thesis like focusing on a digital twin, because the digital twin can tell you which things can be like based on, of course, on infrastructural surveillance, can tell you which things are structural and which things are just like separation walls. And separations walls are not something that you cannot destroy. Like you can move them as however you want and like repurpose them. There is basic changes as all around the hospital that can be targeted little by little to improve the operational efficiency. Especially like right now that we're supposed to, or I hear that there is some plans for a new infrastructure, like is the investment in this infrastructure gonna stay what? Like we have such a good potential that we could have both running at the same time. It's not like, oh, this is all, like architecture is not like something you just like, okay, my phone doesn't work anymore. It stays there forever. It'll take time. I think it will be exactly the same cost to demolish it than to propose the changes.
Okay, my question is if you have ever stopped by at the building F, which is the building that we are working at.
Yes. The one that is not included.
Yeah.
No. No, because that building is not part of the patient, like there's nuclear medicine there, right?
That's true.
Huh?
That's true. There are medical and diagnostic activities there, and patients specifically comes to the second floor for the biopsy. So, and they need to take the elevator to go there. Sometimes they are delivered in a hospital bed, which is also quite stressful because, you know, the corridor to the building F is quite narrow.
Yeah.
So sometimes even if 2 people are trying to, you know,
To pass.
Pass by, they are touching their shoulders. So, so this is the next project for you, building F.
No, because what is fun is like, you know, like there is no possibility of testing because like all the information and all the plans modeled in this project, I just got physical papers and I had to do it myself. There is no like digital information about the center. And I think that's needed. If we want to talk with assurance that like this cannot be modified, is because I have the plans and I can tell you this cannot be modified because all of the wall is structural. But there is an existence of that in the institute, which is a thing that should be addressed.
Okay, one more question.
I have a small one. So okay, it's not a small one. So do you think, are there any means to actually evaluate the real, let's say, medical or like well-being benefit to the patient or to the workers that we can achieve per given, let's say, cost of modification of the space? So that it could be compared, for example, of spending the same funds on some equipment or therapy or something. So can we have...
Can you repeat again?
So can it be measured like the biological benefits to the patient per the cost of, let's say,
so like that there's a thing, and that was like one of the many complex of doing a PhD. Like I cannot measure biological outcomes because of course like infrastructure and biological outcomes are like very far related, like very far not related actually. But I had a very interesting conversation with with these sensors that they're installing on the brain, that maybe like some study could be done about promoting the change of an infrastructure or not. But it's impossible. It is impossible. What I propose, or what I did in my research, is like collect data about the status of the infrastructure, collect data about this patient's well-being with this infrastructure, then promote some change, and then collect data about the well-being of these patients after these changes are implemented. So in that sense, it's like, if the well-being and the quality of life, if I don't know, like there's so many outcomes that can be linked to the infrastructure, the attendance or the acceptation of the building. But still, it's very far from the biological outcome.
Yeah, I think that we'll finish with this one. We have to, let's make applause again, Rafael. Thank you so much, Rafael. Thank you for the attendance. And we have another seminar, internal one. We started in 10 minutes, so everyone is welcome. We have donuts.
Thank you. No worries. I know you. Where were you? You resigned for what?